Hi, my name is Richard Isaacson. I'm director of the Alzheimer's Prevention Clinic at Weill Cornell Medicine and New York Presbyterian. Today, we're going to be talking about endpoints in Alzheimer's disease clinical trials. Let's talk about the Alzheimer's Disease Cooperative Study Activities of Daily Living Scale, also known as the ADCS-ADL scale. The ADCS-ADL is an observer-reported outcome, meaning you have to ask somebody else about their function, about the patient with dementia's function. It's an assessment that assesses both basic and instrumental activities of daily living. These are very important when it comes to kind of getting around, having a quality of life, as well as being interactive in one's life and taking care of themselves. There are a variety of subtests to look at. For example, can the person eat on their own? Can they toilet and bathe? Can they handle their mail? Can they read? Can they write? Discuss current events? Can they find their belongings? Can they put away their belongings? And this structured interview, which is again observer reported, is a total score range anywhere from 0 to 78. The higher the score, the better the function, and the lower the score indicates greater cognitive impairment. Now, there's several advantages for this scale because, first of all, it's designed specifically for use in Alzheimer's clinical trials. It's been used for ages and in many, many studies, and it really tries to understand the meaningfulness in real world life rather than performance on a cognitive test, which may or may not translate into how a person is doing on a day-to-day basis. It actually tries to understand cognitive changes and a translational impact on the person's activities of daily living. Do they have more interaction? Can they take care of themselves? Can they feed themselves, toilet themselves? These are all things that are quite important in terms of a person's everyday life. The other really important aspect here in terms of an advantage is it doesn't just rely on the patient with cognitive impairment. We can use the patient's feedback and cognitive tests, certainly, but when we can use an informant that can give a more of an objective perspective that observes the patient basically handle things in their everyday life, this can be very helpful because a caregiver or an informant, family, friend, etc., can fill out the questionnaire. However, there are also some limitations. Again, it's a long assessment. It's a time-intensive assessment, and you not only need to have the time, but you also need a caregiver that can be able to provide the assessment. Impairment in functioning also is not a characteristic finding in the pre-dementia phases of a person with Alzheimer's disease. So, for example, in the mild cognitive impairment due to Alzheimer's disease phase, may not really be the best option because most of these areas, activities of daily living, should be able to be taken care of by the patient. There also is some issues with bias. A caregiver may be kind of rooting for the patient to be doing better, and thus they can introduce bias to try to artificially increase the likelihood of scoring higher numbers, even when the person can no longer take care of themselves in a way that they used to. Also, some questions cover topics that may not really have occurred between ratings, so it may be more of just kind of a gestalt opinion, and that's not as accurate. And then finally, these assessments may not be relevant for short interval clinical trials. If you're doing a study 18 months, 2 years or longer, then sure, we may be able to more likely see a change in cognitive function as well as a change in activity of daily living. But in shorter trials, we may see cognitive improvements, for example, or cognitive slowing of cognitive decline, but we probably are not as likely to see a change in real world daily activities.